صباح الخير. Good morning, everybody. From Jerusalem, the holy city, the holy land of Palestine, we introduce to you Professor Hassan Rajab, Assistant Clinical Professor, Red Crescent Society International, Consultant of Obstetrics and Gynecology, Red Crescent International Hospital Group. Welcome, Professor Hassan.
Assalamu alaikum, good morning and sabah al-khair, and thank you for inviting me to come here for the second time. I'm working in Dublin actually under Prof Daly's umbrella in the Rotunda Hospital. So we are maybe the first center in Europe who been acknowledged and recognized by AAGL, the American Academy of Minimal Access Surgery, to be a center of training. When I got a phone call about coming here and giving a lecture, I was just thinking about what would be the best, as the majority of our patients are referred to our center are endometriosis. So I just said, let us just update ourselves and refresh ourselves with this very difficult subject. So as we are all aware that endometriosis is an ectopic endometrial-like tissues. It's not typical endometrium. There is a huge difference at cellular and inflammatory level. The overall incidence is really unknown. However, it's about 10% in a total population. This incidence, it could be higher up in infertility group, which could be up to 40%, and about 20 to 30% in women with dysmenorrhea. The whole reason behind, so as you see, this is those type of lesions, they are not a static lesion, they are in a continuous progression, just due to, in fact, the cyclic microcapillary bleeding with consequent inflammation and scar formation. The most common clinical symptoms, the classical triad of symptoms is chronic pelvic pain, dyspareunia, and infertility. If dysmenorrhea is a symptom, it's not due to endometriosis itself, rather than secondary to adenomyosis, which could be in about 30% of cases. Other symptoms could be gastrointestinal or other, depends on the location of the endometriosis. So women could present with cyclic rectal bleed, with tenesmus, or with dyschezia. All of us, when we receive any patient with a history of endometriosis, after history, we examine them. Normally, pelvic examination is very important. In most of cases, actually, we will manage to feel some kind of uterosacral tenderness, nodularity at the uterosacral ligaments, a fixed retroverted uterus, and sometimes obliterated cul-de-sac actually could be felt at the same time. What are investigation? When we talk about laboratory, we have a minimum actually. CA125 is one of the tumor markers. Normally, we don't send it routinely, but it could raise at the end of menstrual cycle, but it's higher above 35 in grade 2 and 3. And CA125 together with PP14, they could be higher up in invasive endometriosis or gastrointestinal one. How do we investigate them? So pelvic ultrasound, as we are aware that pelvic ultrasound is not the diagnostic tool for stage 1 and 2, but it could help actually if there is an endometriomas. And so in endometriomas, normally it shows like a semi-solid mass with no vascularity at the periphery. And the differential diagnosis in this case could be either hemorrhagic cyst or a dermoid cyst. The other sign actually in advanced endometriosis that we could pick it up by ultrasound is what we call a slide sign. if you put a transvaginal probe and if you push the cervix, we watch out at the rectum at the same time. If the rectum is pushed up together with the cervix, that indicate that it could be what you call rectovaginal septum involvement. If we are in doubt, then we send for an MRI scan. MRI, as you see in the top picture, that could see either rectovaginal endometriosis or an invasive rectal disease. And laparoscopy is the gold standard that provides us the chance to see, to diagnose, to investigate, to treat, to excise, to send for biopsy, and to do an appropriate staging. So what are the possible laparoscopic findings? Actually, when you look inside pelvis, it's not necessary when you go in, you look for grade 4 endometriosis. Sometimes you think this is a clear pelvis, but when you check very closely, you can see those type of lesion, a purple lesion, which is the same as invasive nodule, could be a hemorrhagic lesion, and then you could see, especially if you do the laparoscopy at the time of menstrual cycle, you could see a bleeding spots there. Could be a pale-looking lesion in case of scar formation, or a cystic lesion, like if you have a proper endometrioma. How about the staging? So the American Fertility Society, they have 4 types of staging, and that depends on the type of lesion, the size of lesion, the presence of adhesions, and by looking at the cul-de-sac. So as you see, lesions normally in endometriosis, they classify it less than 1 centimeter, between 1 to 3, and more than 3. Looking at the cul-de-sac, whether it is partially obliterated or completely obliterated, and the presence of or absence of adhesions, whether both ovaries are involved or not. Now, as we are an AAGL center, we have a special apps actually in our phone. When we do any diagnostic laparoscopy, actually we go through the apps and then we stage the patient based on that. So we follow exactly right ovary involved, not, left ovary involved, not, side wall, uterosacrals, rectovaginal septums, bladder, all these, and then at the end, it gives us immediately the score. So the scoring system, the staging has nothing to do with the fertility, has no impact on the infertility or with the severity of pain, rather than it tells us about the prognosis and the risk of recurrence, as the risk of recurrence will be dictated mainly by how much you excise during the surgery. So here, an example actually how to stage. When you go in, you look at the peritoneal surface, you check the ovaries, you check the uterosacrals, the side wall, and you check for adhesions, and then based on that, you just score it, and then you will come up with a final stage. So as we say that up to 5 stage 1, up to 16 stage 2, more than 40 actually normally stage 4. So most of the cases when you go in and you have an obliterated pouch of Douglas, then you say this is stage 4 straight away, as it scores 40 by definition. So if you take a biopsy and you send it to the lab, you don't need to have a full picture to say this is an endometriosis. You need at least 2 out of 4. So you need to look to find what we call an endometrial cells, which is the columnar cells, the endometrial stroma, and glands plus macrophage. We can't see it here because we need high power zoom. So if you have 2 out of 3, then you put diagnosis of endometriosis, which is very important to avoid any false positive result. And that's very important for counseling and long-term management. So what are the theories behind the development of endometriosis? So the classic theory by Sampson, who thinks that it's mainly due to backflow during menstrual cycle, and those endometrial cells, they will seed and they will grow. And he supported his theory by implanting an endometrium on the sheep's eyes, and then it found that was growing. That could explain the most common anatomical site of endometriosis, but the theories that was rejected just because they found it in amenorrheic patient and in some men as well. So the second theory, which is by Mayers, who said that it is due to coelomic metaplasia, and the whole idea that there was unknown trigger that could trigger differentiation of coelomic epithelium into endometrial type of cells. So lymphatic spread or vascular, that could explain distal metastasis. Other theories, what you call activation of Wolffian rest. As you know, in women, Wolffian duct will regress into epididymis in men. So persistent Wolffian duct could trigger endometriosis as well. So how endometriosis could affect fertility? At different levels, actually, could be secondary to a mechanical damage. We know that it could cause some adhesions, scarring, hydrosalpinx, destruction of ciliary movement, and when you look at the peritoneal fluid normally around the eggs or around the ovaries, it will be full of inflammatory cells that could enhance phagocytosis. At the level of endometrium, there will be high level of macrophage, and that could prevent implantation. And overall, in women with endometriosis, there is a significant drop in AMH level, and especially if they go for any surgical procedure, as the AMH level could drop by 30% if any patient goes for any kind of surgical excision. The other effect could be hormonal dysfunction, and women normally with endometriosis, they have a defective folliculogenesis, and normally there's a resistance to LH. In stage 2 and 4, there's high risk of hyperprolactinemia that could affect ovulation indirectly. And luteal phase insufficiency, which is secondary due to an ovulation as well. So overall, there are an abnormal fertilization, implantation failure, and early spontaneous miscarriage. So the question here, what do we do? Do we need to go for surgery? Do we need to start medical treatment? And if you decide to go for surgery, who is the candidate for surgery? What type of surgical procedure? Are we going to cure them? Are we going to improve their life? So these are very important questions, actually, we need to ask ourselves before we go for any surgical procedure. So medical treatment, I'm sure that most of us, we are aware of it. We start by NSAIDs. They are good for pain control without effect on the endometriosis. Likewise, Carbomaxol, which is NSAIDs and paracetamol. The pill, contraceptive pill, are the first line of treatment. Normally, if you have to give them, you have to give them continuously for at least 3 months. And it's preferable to start with high estrogen, 30 to 35 microgram, rather than small dose estrogen pill. Progestogens, they are good because they help the visualization of endometrial cells, as all studies shows that ectopic endometrium, they have high level of TNF alpha, and by giving progesterone, that helps with this visualization. Progesterone antagonist, which is mifepristone, which is normally the treatment we use as emergency contraception. So by giving 50 milligram, it has a good effect on pain, but has nothing to do with, it doesn't have any effect on endometriosis at all. Dynogest, which is now, it's commonly used in Ireland, which is the Visan or Zafarella. They are progesterone receptor agonists. They are good, just a little bit expensive. They are as effective as GnRH analog. The dose is about 2 milligram. Danazol is very effective. We don't use it due to its side effect. GnRH analog, again, they are very effective, but their use is limited due to their side effect profile and their effect on bone density. So we normally give them up to 6 months, and then if we have to give an back therapy, we have to give either tibolone or a combined estrogen and progesterone to avoid excessive endometrial stimulation. Aromatase inhibitors, so letrozole, which is, it has against estrogen agonist activity on the endometrium. If you decide to give it, it's very good effect in terms of pain control. However, if you have to give it, you have to give it together with the progesterone as well. So gestrinone is, again, it's very effective. It has both antiprogesteronic, antiestrogenic, antigonadotrophic, with less side effect in comparison to danazol. We don't use it, I don't know why. All other agents are just under trial, actually. So what type of surgical treatment and what indication? So for large lesion, normally we go for surgical intervention, or if failed medical treatment, or in a woman going for fertility treatment prior to IVF, and or if family complete. Or if the patient has some kind of medical complication or surgical complication of endometriosis, such as bowel obstruction or ureteric obstruction. So surgical option, as all of us we are aware, so it could be conservative or radical. And if we opt for conservative, we could add any denervation technique actually to control pain, which is in the form of LUNA, which is laparoscopic uterine nerve ablation, or presacral nerve stimulation, actually. Sorry, presacral neurectomy. So conservative in women less than 40, and they have desire for fertility with a mild disease. So it could be surgical excision versus ablation. Excision is much better in a long term to avoid recurrence. Ablation is a straightforward procedure. We need, in order to do a proper excision, you need the proper devices. So many in the market, such as laser, ultrasonic, plasma. And presacral neurectomy, you need an expertise to do it. Radical, in a woman who is above 40, or if her family complete, and the decision whether to go for hysterectomy, plus minus PSO, or to preserve the ovaries, we'll come to it later on. So with the excision, normally use a cold scissors or harmonic to excise the endometriotic lesion, and go after each lesion to remove. So with complete resection, the risk of recurrence is almost zero. Before, we used to tell that the risk of recurrence is there, whether you have a complete excision or not. With the new data, they showed that with complete excision, so you might just get excellent cure rate. So here again, there is an invasive nodule in the left side. This is the best treatment for this type is just to excise it. And again, if radical resection for what you call cul-de-sac endometriosis. Here again, excised lesion and scar. So in the left side, that lesion was excised, and the other lesion was ablated by laser. So what do we do with endometriomas, especially when with ladies who are going for infertility? Do we excise? Do we ablate? So normally, once you diagnose it, you just open the ovary and then you start to drain it, and then you excise the cyst wall. With the excision, it's better in terms of recurrence, in terms of pain control, but it has a major impact on infertility, because with excision, there will be a drop in AMH level and antral follicle count significantly after excision. With the ablation, it's better for fertility, but it has a high risk of recurrence in the future. And here again, this woman, she had a bladder endometriosis. Cystoscopy showed endometrioma. That slide showed a bowel endometriosis, deeply invasive. Here, a bladder endometriosis that was seen laparoscopically. And again, actually, obliterated patch of with endometriosis. So it's a nasty disease, actually, so it needs really appropriate skills to deal with it. So here again, actually, so that's a specimen of the rectum, showed full thickness endometriosis that invade the rectum. So when you have rectal endometriosis, in our center, we go up to discectomy or shaving. When it's very deep invasive, we send them to endometriosis center for rectal excision. So with endometriomas, as we said, if we excise what we call radical treatment, there will be an impaired ovarian reserve. But it's way better in terms of recurrence. If you do what you call a conservative approach, it's better in terms of fertility with the risk of recurrence. So overall, the overall recurrence rate of endometriosis is very high, estimated about 21% at 2 years and 40% at 5 years. At 36 months, when you look at this slide, actually, the recurrence rates depends mainly on staging. So as you see, it's higher in stage 4, lower in stage 1, and this highest recurrence state is mainly due to incomplete excision. So how about endometrioma recurrence? So endometrioma type 2, which means that endometrioma that raised in the top of corpus luteal cyst, and in the other side is the endometrioma type 1. So when you look at the control and the type of treatment, normally with the excision, there is a significant drop of antral follicle after excision. So if we opt for conservative treatment, it's good to deal with endometriosis, but it will be advisable actually to provide any kind of pelvic denervation procedure, such as either LUNA or presacral neurectomy. So the presacral neurectomy is very effective for a central type of pain, talking about dyspareunia and dysmenorrhea. And it needs special skills, where the LUNA is an easy procedure. Actually, all what you have to do, you have just to divide the uterosacral ligament at their attachment to the back of the uterus. And the presacral neurectomy, so we did a few cases. Now, the only problem with them, it has a significant risk of constipation and bladder dysfunction. So we have one lady who was going for 3 monthly Botox injection after this procedure. So presacral neurectomy, so here this study shows that there's a significant improvement of dysmenorrhea, and the dysmenorrhea cure rate with conservative treatment and BSN is about 80% in comparison to 57% without neurectomy. And at 24 months follow-up, 83 to 53. So there's significant improvement with central type of pain in terms of dysmenorrhea and dyspareunia if we do presacral neurectomy in comparison to without. And again, this is the meta-analysis showed the same. There's significant improvement actually, so women with or without BSN. So in all, there's about 88, 83, and 86% improvement. So what are the limitations of presacral neurectomy? It's effective only for midline type of pain. It needs expertise, and it has its own side effect and complication. So LUNA, actually we used to do it, but now we are not doing it anymore just because at 5 years follow-up, there is no significant improvement. The satisfaction rate with or without is in the region of 75%. Hysterectomy, I know this is the final result. Now the question, do we need to remove the ovaries or not? The general concept, yes, remove the ovaries if endometriosis is the cause, but appropriate counseling is very important. The difficult part here, if you decide to remove the ovaries, are you going, especially in a young patient, are you going to give them HRT or not? Whether HRTs are safe or not? So you have to have an appropriate counseling. But it's definitely if there's a significant improvement in terms of recurrence of pain and reoperation if you remove the ovaries. So if you keep the ovaries, the risk of recurrence of pains is about 6 times higher and 8 times for reoperation. So removal of ovaries at definite surgery. So as you see here, there are 2 studies. The odds ratio is about, the risk of recurrence is about 10 times and 2-fold in both studies. So removal of the ovaries, yes, is an indicative. Just you have to have an appropriate counseling with the patient. So what we do in our unit, actually, we counsel the patient. They have to understand they are menopausal. They should understand what menopausal symptoms are. They should understand that giving the HRT, it may or may not be helpful. And then most of the cases the final decision will be, okay, we'll go in. If we manage to do radical resection, and if we have 100% resection rate, then it will be advisable to give estrogen to them. And if the ovaries are not involved, we leave them, bearing in mind that we might need to go back and remove them at some stage. Finished? Okay. So as we said that endometriosis and HRT, normally if you have to give, it should be continuous combined. If you give estrogen only, that it could trigger some cancer changes in the future. in the form of clear cell carcinoma. And if you have to give, you should add testosterone as well. So the NICE guidelines, so just a quick reminder of the NICE guidelines. So it's very easy, very simple. So if you have any patient referred to you with history of pain and clinical signs and symptoms suggestive of endometriosis, so if they are, then you have to categorize them. Are they seeking to get pregnant or not? If not, you give them NSAIDs and the pill for 3 months back to back. If there's no improvement, you send them for laparoscopy. If they are seeking to get pregnant, you investigate them for infertility. And if they are trying for up to 6 months, then you refer them. Thank you very much.
Thank you for your lecture. We hope see you in Syria.